The Valsalva maneuver remains one of the most elegant, non-invasive bedside tools in our clinical arsenal. Because it produces a predictable 4-phase sequence of hemodynamic changes, it allows us to dynamically alter preload and afterload to clarify diagnosis and terminate arrhythmias without pharmacological intervention. To leverage the maneuver clinically, we rely on the physiological changes occurring across its 4 distinct phases, typically a 10 to 15 second expiration against a closed glottis, ideally generating 40 millimeters of mercury pressure. Phase 1, onset of strain. The sudden increase in intrathoracic pressure mechanically compresses the aorta. This causes a transient increase in blood pressure and a brief compensatory vagal decrease in heart rate. Phase 2, continued strain. Elevated intrathoracic pressure impedes systemic venous return. Preload drops significantly, leading to a fall in cardiac output and pulse pressure. The baroreceptors sense this drop, triggering a sympathetic surge, causing reflex tachycardia and increased peripheral vascular resistance. Phase 3, release. Intrathoracic pressure suddenly normalizes. The pulmonary vascular bed expands, temporarily pooling blood and briefly depriving the left atrium of volume. This causes a transient sudden drop in blood pressure and a further spike in heart rate. Phase 4, recovery. Normal venous return rushes back into the right and left heart. Because peripheral vascular resistance is still elevated from phase 2's sympathetic surge, stroke volume normalizes against high afterload, causing a blood pressure overshoot. This overshoot triggers robust baroreceptor firing, resulting in reflex bradycardia, the phase most responsible for arrhythmia termination. Diagnostic uses the bedside stress test. By dynamically altering ventricular filling, preload, and systemic resistance, Valsalva is highly effective at differentiating structurally complex murmurs and assessing filling pressures. In hypertrophic obstructive cardiomyopathy, murmur becomes louder in phase 2. Mechanism: decreased LV cavity size brings anterior mitral leaflet and septal wall closer together, exacerbating the LVOT obstruction. Mitral valve prolapse. In phase 2, click occurs earlier, murmur is longer and louder. That's because of reduced LV volume causes redundant chordae, leaflets to prolapse earlier in systole. Aortic stenosis, for contrast, murmur becomes softer. Decreased stroke volume means less flow across the stenotic wall. This helps to distinguish aortic stenosis murmur from murmur of hypertrophic obstructive cardiomyopathy. Assessing left-sided filling pressures. In normal physiology, the blood pressure drops during phase 2. However, in patients with heart failure and significantly elevated left ventricular end diastolic pressure, more than 15 millimeters of mercury, you will see a square wave response. Because these patients are heavily volume overload, the transient drop in venous return during phase 2 does not actually deplete their pulmonary venous reservoir. As a result, stroke volume and blood pressure do not fall, and the reflex tachycardia and phase 4 overshoot never occur. Therapeutic uses: rhythm control, terminating supraventricular tachycardia. Valsalva is a first-line class 1 recommendation for terminating hemodynamically stable AV nodal reentrant tachycardia and AV reentrant tachycardia. The sudden spikes in vagal tone, briefly in phase 1 but profoundly during the blood pressure overshoot in phase 4, increase the refractory period of the AV node, breaking the reentrant circuit. The modified Valsalva maneuver, according to the REVERT trial, standard Valsalva in a semi-recumbent position historically yielded a relatively low conversion rate for SVT, around 17%. The REVERT trial 2015 revolutionized this approach. The patient performs the standard strain, 40 millimeters of mercury, for 15 seconds in a semi-recumbent position. Immediately upon release, the patient is laid flat and their legs are passively elevated to 45 degrees for 15 seconds. The passive leg raise dramatically increases venous return right at the onset of phase 4. This magnifies the phase 4 blood pressure overshoot, leading to a much stronger baroreceptor reflex and a massive vagal discharge. This simple postural modification improves SV determination success rates to over 43%, significantly reducing the need for adenosine.